All righty. Hello, everyone, and welcome to our ArPA, the Arkansas Psychological Association's virtual event. I guess our second virtual event. We had one yesterday evening, and thank you for those who were able to join that, to be a part of that virtual event, and then also a part of our fundraising efforts. So everybody's appreciated who was involved in that with the planning and also in the participation. So as you know, I'm just going to go ahead and jump into our virtual event today. And thank you for everyone who has joined. And so if you have joined as an attendee, so the only people that we can see and hear, you might notice that I might respond to some of the comments I see in the chat from time to time. So just so people who know, who are on, we can only see and hear the panelists. So otherwise you are an attendee and we cannot hear you as an attendee. We can only hear the panelists because we have this set up as a webinar. However, you are welcome to send messages through the chat. Okay, so as ArPA, what we do try to do as ArPA generally, and certainly as the Professional Development Committee. So hello to everyone. Let me introduce myself first. My name is Khiela Holmes, and I am the chair of our Professional Development Committee. And as the Professional Development Committee, we put on different events that we hope are timely and relevant to kind of what's going on, to what our membership and psychology professionals and other mental health professionals would like to hear about. So we typically do an in-person spring conference, but of course that did not happen this year. So we really decided, and everybody, this is what ArPA does. ArPA really just decides to get on board. And even though I know everybody has a lot on our plate, including the panelists. So if everybody can give a virtual hand clap to our panelists who were willing to take out of their time to be a part of this, because I know everybody is busy. So, but in that, this is what ArPA does. We like to come on board and rally together to make sure we provide information that, again, is timely and relevant to other psychology professionals, and again, just mental health professionals who would benefit from the information. So that's what we're doing here today, is presenting some information regarding ArPA's response to COVID-19 and some of the legal, ethical, and practical considerations for telehealth. So that's our focus for today, is looking at different aspects of telehealth, some considerations to keep in mind. And also throughout, you may hear us reference different resources that can be accessed. So please know this is just one of many resources. I know everyone has looked in some information through APA, through their malpractice organizations and others that have provided very helpful information. Of course, the Psychology Board, the Arkansas Psychology Board, and others that have provided relevant information for telehealth. We just hope that this can serve as an additional resource as you dig into information regarding telehealth. So for some housekeeping information, several people have emailed me to wonder if this will be recorded. So yes, it's being recorded. It is recording now. And hopefully within a week of today's webinar, we will have it posted on our website or somewhere that will be accessible for people to be able to see. And for those who registered for CEUs, there will be 3 CEUs provided for today's webinar, and we are keeping track of that. So you will be emailed a certificate after today's webinar indicating that you have completed the requirements for the CEU. So if you have not received that within, about a week from today, please email us to let us know, but we hope to have that out very shortly after today's webinar. We will have breaks today because we know that 3 hours is an extended period. So we will have a couple of about maybe 5 to 7 minute breaks or so throughout today's webinar. There will be, as I know a lot of people, I'm doing several housekeeping announcements, but I know a lot of people have been doing Zoom or some other video conference feature within the last month. So you might know that kind of depending, there may be a slight lag time in when one person talks and another person speaks. So please kind of bear with us with that if that does occur throughout today's webinar. Also, I will keep an eye on, so I'll be the moderator for today's webinar, and I will be keeping an eye on the webinar chat feature. So you'll notice at the bottom of your screen, if you were to kind of use your mouse to hover over the bottom of the screen, you'll notice that there is a chat option. So you can go and click on that, and it'll appear, well, I guess depending on your screen, but it'll appear on my screen is to the right, a Zoom webinar chat. And as you see, you can send a message to people privately, you can send a message to the panelists, or you can send a message to the panelists and attendees. It gives you several options. So I will keep an eye on that if any questions were to come up throughout our webinar today. Also, if there's time at the end, we may, if people have specific questions that they would like to come on live and ask, if time permits towards the end, there is a way that specific attendees can be unmuted. I might just use that feature to unmute if people are not quite wanting to be on video. But we will do that if there's time towards the end. Okay, panelists, are there any other announcements that you all have that you want to add? Are we ready to jump in?
Looks like we're ready.
All right, okay. So what I'm going to ask, we're going to go ahead and get started. Attendees, somebody's asked a quick question. Attendees are not viewed by the panelists. We can see who is on, we can see your name, but at least I am not able to see anybody's pictures, but we do know the names of the people that are on. So we cannot see video, we cannot hear audio unless one of the hosts go in and unmute somebody. So yeah, so no, we cannot see anybody's video nor hear anybody's audio. All right, so if we're just gonna start, and I'm just gonna ask each panelist to introduce yourselves and just give a little information about you, because we have people on who are very familiar with ArPA and ArPA members, but we also have people on who are new to ArPA. So I might just start with Dr. Benton, Dr. Adam Benton. We have Dr. Adam Benton, Dr. Tisha Deen, and Dr. Joyce Fowler, who are supporters and advocates and participants within ArPA and also within the psychology community. So Dr. Adam Benton, if you don't mind getting us started.
Sure. Like you said, I'm Dr. Adam Benton. I am a child psychologist at Arkansas Families First, and I've served as ArPA's president in the past, and a couple other positions like Early Career Committee chairperson and Federal Advocacy Committee chair. I've been using telehealth for a few years, but not as full-time as we all are now. So it's looking forward to a good discussion today and have a lot of things to say about telehealth. So thanks, Khiela.
All right, thanks, Adam. Tisha, if you don't mind going next, please.
Sure. So I am Tisha Deen, and I am a psychologist at the VA and also in private practice with Joyce at the Fowler Institute. And I have also served as president of ArPA. I serve as the chair of the Government Relations Committee, work with PDC, work with the membership committee, and whatever else we decide to do. I'm primarily focused working with adults and have some specialty in dialectical behavior therapy and in integrated primary care. So at the VA, I work integrated here. I'm at the VA right now. So I work in integrated primary care at the VA. And I also, as a postdoc and throughout my career, I have really been interested in telepsychotherapy and using telemedicine to increase access to evidence-based practices in rural communities. And so as a postdoc and throughout my work, I have done telemedicine for about 10 years now. So just have some practical experience with it over the years. I think that's it.
Oh, thanks a lot, Tisha. All right, Joyce.
Okay. Dr. Joyce Fowler, and I am private practice at the Fowler Institute, and we're happy to have Tisha there with us. So good to see her here. We only get to see her a couple of evenings a week since she's full-time at the VA. I've been active in ArPA since I was a student. I joined ArPA when I very first started my PhD program and have been a member ever since, and got active in early career, various different committees, legislative, PDC, fundraising, and I'm a past president. I believe it was 2010. And really have found ArPA to be just really key part of my professional life. And I appreciate everything that all you leaders do to help with the profession. So telepsychology, we started with Zoom, I believe, back in 2016. And it was something that people in the clinic just weren't that interested in more. And we seem to use it more in kind of training or for meetings, things like that. So now we're 100% telepsychology right now. And hopefully to be getting back in the office face-to-face again soon.
Well, wonderful, wonderful. Thanks everybody for providing that introduction. And as I'm just keeping a note again of our chat. So if you hear me say something or I'm sometimes responding to a chat. So if our panelists, if you could just make sure if you have a mic or something like that, if you could just be sure you remain fairly close to the mic so you're heard well by our attendees and then it's captured very well on our recording. Thank you. So what I'm going to do is just go ahead and get started. And so what we're going to do today, we kind of have it divided into, the questions divided into 3 different categories, even though they might overlap some. So we're going to start with legal and ethical considerations and then move into implementation when we talk specifically about topics relating to clinical practice with therapy. And then also we'll talk some about assessment. That question was sent in and somebody wanted to hear specifically about assessment. And then of course, we'll talk about technology and the use of technologies people experience with different forms of technology when doing telehealth. So let's get started with legal and ethical considerations. And certainly the first that people may wonder about is how are people handling, and if each panelist, if you don't mind, you'll notice with some of the questions I might ask each of you all to respond, and then it may be some that one or the other based on your expertise may be more likely to answer. But this may be something for each of you all. If you could speak some to informed consent with telehealth, how you're handling it, you know, even whether it's specific forms that you're using, just how you're handling telehealth. So how you're handling informed consent. Whoever wants to get started, I don't know.
I'll jump in. Can you hear me better with these microphones? Somebody had said they couldn't hear me. Is that better?
Yes, that's better.
Yes, that is. Mm-hmm.
Okay. All right. Very good. So we already had a informed consent that we were using. However, if many of you probably saw one came out, a sample one came out from APA. And so we got that and updated. The other thing that I've done, and I'm waiting to hear back, is I sent it to our attorney who specializes in this in healthcare, and asked her to take a look at it to make sure that it's up to what it needs to be for Arkansas law. So that was an additional thing that I'm waiting to hear back from.
We also had a telehealth consent form in place when the COVID issues started, and our clinic began switching over to telehealth almost 100% over the course of a week. So the dilemma that we had was that although we had the form, many people were starting telehealth who had never had a conversation about telehealth before because of the way COVID unfolded. And so I think that was kind of a dilemma that we had to address. And the way that we addressed it was by adding consent checkboxes and to our therapy note templates. So before each session, or before the first session, we would send the telehealth forms, consent forms to patients and have them review it. And then we would get verbal consent that they've seen and reviewed the form. And then we try to, our front desk staff is trying to collect those actually signed forms too. So we have kind of the verbal consent in session and also the signed consent. And we felt like that allowed us to move forward without delaying therapy in the process.
Adam, did you say you're using therapy notes?
No, we use Practice Suite.
Okay. Yeah, we use therapy notes, and we were able to upload the telehealth form. So we've done it both ways, where we gave it to people by paper, either fax, or when they were coming into our office, do it that way or mail it to them.
Mm-hmm.
But we're able to upload it onto therapy notes along with our intake paperwork. And each person sets up, and the portal has a portal. And so they're able to open those forms and sign them electronically.
Yeah. This whole COVID process has really, I think, given us, an opportunity to make the most of the software, like practice or simple practice, a practice suite, and therapy notes all have portals that sure make it easier to get forms like that, to get intakes, paperwork taken care of. And we were sort of a hybrid with ours. Some of the processes we used and some we didn't. So we're kind of diving back in to figure out what all we can do digital that we weren't doing before.
Yeah. Adam, if you could, while you're just speaking, if you don't mind speaking a little bit to any differences between getting consent for the children, for the minor patients, and then the adult patients. How did that look different?
So the consent for child patients comes through the parents. Obviously, they give consent for their child to use telehealth with the provider, and then older kids can give assent also. But the consent goes beyond the forms. It's really about understanding the process of telehealth, and I think that's the conversations that we were having when we're checking our consent box, was what it really means to be on telehealth. What are the security, if there's security concerns, some of the pros and cons of using it, how it's going to be different, just getting expectations on the same page. And also talking about emergency procedures, and such as, where is the patient located at the time of the service? Is it really a private location? Or things that, for myself, for instance, in working with kids, what materials might that child need to have therapy telehealth? Whether that's certain toys or coloring sheets or whatever. Just having conversations about what therapy online is going to mean and look like for a family is part of that. Is a key part of that consent process.
So it seems like with informed consent, you're talking about in different kind of aspects. So actually having the form that so they can provide that verbal consent, actually have a form, and then actually really make sure they fully understand the process and all of what's involved in it, of course.
Right.
Yeah. Okay. I'm going to address some attendee questions in a sec, but Tisha, what did you want to add regarding your process?
So my process is the same as Joyce's process in private practice. In the VA, we've been doing telehealth for quite some time, and so a lot of that stuff was already in place. We have specific templates that make sure that we go through the different informed consent, and that the veterans understand. I think a big piece of it is helping them to recognize that because they may be at home in different environments, that their confidentiality and safety is a little bit different, and to think about, are you in a place where no one can hear? Do you feel like you can talk candidly? Is this a good time? Even though we had a scheduled appointment, things can happen. And so just, making sure that they think about those things, and, thinking about their safety. So making sure that they are at the address that you think they're at, and that you have a good phone number, and that they're aware that you're thinking about those different aspects of telehealth, because it's not the same as if they're in the room with you. If they're alone versus if they're in the house with other people, and just things to consider that way.
Right. So it seems like
And
it's several kind of preliminary conversations to certainly have. Joyce, were you going to add something?
Yes. There was also with the APA Office and Technology checklist that was sent out. There was a section in there about when you begin your session, things to be thinking about. And we took that and converted it into a checklist in our office that we would use just to have as sort of a cheat sheet each time we have a session. And that's really critical because part of it is critical for the patient in the sense of if there is an emergency situation, you know where they are. For example, I had one of my regular clients who was obviously someplace different, and I asked him where he was, and he was in another town at his girlfriend staying with her for the week. So I got the address there, made sure I had the phone number and the address, and so thinking about those things, and that's part of the Telemedicine Act, is those kinds of things you really need to think about because it's a requirement that you document that in your file.
Okay. Thank you so much for that, Joyce, adding those resources. So you all attendees might realize that from time to time the panelists may add some resources. So thank you, Tisha, for putting that in the chat. You all might notice if you access your chat that Dr. Deen has inserted the link to the APA checklist that Joyce referenced. That link is in our chat. Thank you very much. Okay, good. Somebody, there was a question regarding when is the informed consent obtained? So I know this was a rushed kind of situation, so it might be different between if we were doing telehealth outside of COVID-19 and now with COVID-19, but if you all could address that, was that actually done during the first telehealth session? Was that done prior to it? And then how is that? I know, Joyce, you mentioned that being in the portal somehow, if you have an electronic medical records where that can be uploaded to a portal, but then how is that placed in the chart? So when is it obtained and how is it placed in the chart?
It needs to be obtained before you provide the service. And so what we're doing is not everybody has access to the portal, and the governor did the loosening of the law, the telehealth law, so that we can do phone sessions as well. But we are trying to get that, the informed consent needs to be gathered before. So, you know, it may be that you mail it to them, it may be that you fax it to them, or sending it electronically if they have that capability. You know, I think we've got a little bit of leeway, I think, in terms of HHS, in terms of finding us right now. So, you know, one of our clinicians ended up talking to someone on the phone, an existing client, and it was kind of sort of a unique situation of somebody who was sort of delusional, and they had refused doing telepsychology at first, but then later decided to do telephone sessions. So we had to figure out how to get that informed consent. But so that one was a little bit backwards. And so the way the clinician handled it was doing a verbal informed consent, you know, just on the phone. And we eventually got the signed one. But that was kind of an unusual, but really you should get it first before you see. So what we're telling our staff is when they're scheduling appointments, if they're not set up for telehealth, our staff are trained to help people walk through the process of how to get on the portal or how we can get that information to them. So they get that done before we actually see them, either by phone or video.
Okay, great. Thank you. Anybody else want to add to that?
Yeah, I'll just add that now that have sort of switched to this telehealth, almost entirely telehealth mental health practices across the state, that, you know, a lot of the intake packets that people use now are including telemental health. So as new patients come in, they're completing that before before new patients Zoom in, they're completing the telehealth packet in the consent form digitally or on paper and sending it in digitally. So that can be taken care of. But I just want to stress, like, if a form doesn't give them understanding, a form just kind of covers you, and so that should be part of the first session, whether that's in person or in the current status, if that's online. They need to have a thorough understanding of telehealth.
Yeah, and I want to jump on that because I think, there's legal informed consent, like we have a signature that they said okay, and then there's actual informed consent. And I think part of it is education about, for us, we try to learn how to do this in a way that it's the most effective way, but also teaching them, like, it's really important that you have a place that's quiet and that you feel safe, and that you're sitting somewhere and I can see you and I can hear you, and that you're not roaming around and throwing your phone. Again, just like we do when we orient people to therapy, this is how it works, this is how we meet, and these are the things that we work on, and these are the the goals, and it's a piece of that too, is okay, this is how this is going to be most effective for this to work over this medium, because we're new to it and they're new to it too.
Yeah, and
it's kind of informal to them, I think, sometimes.
I think so too. I think with that also comes, for some clients, an excitement about it, and for others an anxiety about using it, and about the security, or about being watched or monitored by outside organizations. I think there's all kinds of different anxieties around using a medium like this for some people, although others feel more comfortable and more at ease. So it's just part of, I think, kind of that initial assessment process.
Yeah. So kind of related to that, how have you all been handling, especially if it's a new patient, in the initial intake? I know, this conversation, obviously, generally speaking, of course, my understanding is that the parameters would be, of course, to see the person in person, face to face first. How are you all thinking about this during COVID-19 in the initial intake, doing that via telehealth? And are you finding that insurance is covering it? And somebody asked specifically about this for kids, but we can discuss that in general. The initial intake, that being done via telehealth, and is insurance covering it?
I think it might be important here, before we get too far into it, to clarify that there's two major sources of sort of regulation. One would be our APA telehealth guidelines, or telemental health guidelines, that the board requires us to follow, but then also the state law. And Dr. Fowler may be more able to speak to this, but those are the two sources of information that are sort of guiding our practice. And then certain aspects of the law have been relaxed by the governor so that we can practice more freely during this time. Dr. Fowler, do you want to elaborate on that at all?
Well, the Telemedicine Act is, as psychologists, well, really all mental health professionals are required to abide by that. And it was passed, I think, in 2017. And, I've talked to a number of people who really didn't realize that it was out there. That we're required to follow that law. And then for psychologists, we have as Dr. Benton said, the APA guidelines for telepsychology. So those are two important documents that are used by the board. And then thirdly is, and you can go to the Arkansas Psychology Board to find links to all of these. The board has passed new rules and regulations, not passed them, but rewrote the rules and regulations last fall. They went to the governor, I think last July. And they kind of labored in the length of a long line of rules that were waiting to come out of the governor's office. And just because there were so many with the restructuring of government, all the boards were redoing their rules. So when the COVID crisis came along, the telepsychology was addressed in the new rules, but it's not in our current rules. So we were left without any rules and regulations when the COVID crisis hit. So the governor got our rules and regs approved in his office, and so they're out now for public comment, and that phase will be over fairly soon. But since there was a process in place before the rules could be finalized by the legislature, then an emergency rule was done. And what they did is the attorney generals that works with us took those out of copied those out of the rules and regulations, and an emergency legislation was passed so that we could function and have rules and regulations in place. So that rule is also on the website, so you need to look at that. That's what guides us right now. There is a part in there where you're supposed to be trained in telehealth as part of your scope of practice. However, because of the crisis, the board waived getting that documentation for 120 days. So people have I think it behooves us all to go ahead and get the training we need, like what we're doing today. And there's a lot of free trainings out there right now on telehealth. So telehealth, telepsychology, telemedicine, a number of different places. But I encourage everyone to, take advantage of those free trainings to get up to speed.
And I included the links to those, to the practice guidelines, and then to the board where it has those documents.
Yeah. Thank you so much, Tisha. And just so we know, when we're referring to the board, because I know we have some attendees who are not psychologists, so we are referring to the psychology board, but hopefully with whatever your kind of governing board is, hopefully they have information on their website to provide that guidance as well. So if we could follow up with that, I don't know if Joyce or Adam or Tisha, who wants to address that specifically with your understanding of the guidelines and what guides our practice right now. What are your thoughts about the intake and how to think about
You want me
My
to-
Go ahead.
Go ahead, Joyce.
Go ahead, Tisha. Tisha, go ahead.
So, one of the things that I have, I said I did research in telemedicine and have been kind of working in mental health for a while. And so, a lot of what has been shown is that whenever you look at effectiveness, that our interventions are effective in both realms, whether you do it in person or you do it over a video connection. And so, I think part of it is that I think for me, and I think for us is to recognize is that although it may not be the same and it may not feel the same, and there may definitely be some different ways of doing things, that it's generally accepted as an effective way to do what we do. And I've done a lot of first initial assessments with people over telemedicine through the VA, because we have different kinds of guidelines and things that we can do. So, I think that although it's not ideal, it's definitely something that's doable if we're able to recognize that we may, need to ask different questions, or, may need to, think about things in different ways.
Go ahead.
I was going to say, since COVID started, I've done a few intakes and have not felt like it's reduced the quality of the intakes at all. Before COVID, of course, we would have had to have them in person first, so that would have taken place.
And I think, like Dr. Benton said, kind of revising your intake paperwork that's done ahead of time can be really useful. And if you have that ahead of time, then there's a lot of information you have already going into the intake, so that's helpful.
As far as the insurance question, I've not heard of insurance paying for intakes on telehealth. Has anybody else heard that? No.
I haven't checked to see if they process them. We've filed for them.
Somebody just said that Medicaid just approved intakes for telehealth, and that's what I would expect to be seeing, is that insurances would start making continue making policy changes to adapt to this time period. So I would expect that to happen, but I don't believe that the intake code was one of the codes that I saw on a Blue Cross letter, for instance, listing out codes. So
right.
So I know that some are down billing to counseling code instead of an intake code, is what I've heard others talk about doing.
And I kind of want to piggyback on what Joyce said. I think, a lot of the intakes I've done are from the VA, and one of the things that's very helpful as being in the VA system is that we start out with a lot of information. Usually, we have access to all their medical records, from some people decades of medical records. So the more information that you can get on the front end to have as far as their experiences and their other treatments and diagnoses and anything that you can get that kind of helps give you a context, that's helpful in any intake. But I think sometimes whenever you feel like you're missing some personal information via having them in the room, having more collateral and just background information can be a really helpful way to bridge some of that.
Okay, thank you, you guys. Thank you for panelists for addressing that. I'm wondering if we can we're going to stay within the realm of legal and ethical considerations, but one regarding that, someone had this question, and I've seen this in some of the material, is how to handle it. Let's think about specifically with kids. It's a couple of questions specifically about children and adolescents. How do you handle it if it's going to be another party that's going to join telehealth? Right? So if it's another caregiver that's going to join, or if you're gonna the question is more around who to email the link to. Can you send it to one person and have them forward it to the other caregiver? Or even in the situation where you're just meeting with the teen, can you send it to the teen's email address, or does it have to go to the caregiver and they work that out? How are people handling that in terms of who to send the link to, and whether it's okay for them to forward the link to somebody else?
I always send the link to the parent, and then the parent can arrange for the child to forward it to the child if that's what they want to do. But I would rather go through the parent than directly with the child. But just to say, but even before that consideration, really, there's 3 different ways that you can join or set up a Zoom call, for instance. I'm sure that Simple Practice and Doxy.me has similar process, but you can send a link to a video or an invite that's to a video that's already started, or you can schedule a meeting and then they can you can send them the invite so they can just join the meeting whenever they're ready. Or you can use what's in Zoom, what's called a personal meeting room, which is like a digital space reserved for you. It is attached to your ID. So at any time they can go to Zoom and hit join me and put in your ID, and they'll pop up in your meeting room. So you don't even have to send a link to them at that point. Now, with some of the security things that have been going on with regard to Zoom, they've made it default now that if a client puts in your ID, they can't just pop up in your screen. They'll be put into a waiting room, and you have to admit them into the session. So it works like a digital waiting room, just like in your office. So if they show up early, then you're in another session. They're having to wait until you admit them into the session. But to get to the real question, I guess I would send it to the parent first. Every time.
Okay, every time. Okay. And related to that, someone had a question about, and specifically to you, Adam, regarding the youngest client that you've seen via telehealth and how you handled confidentiality with the younger kids.
The confidentiality might depend on the specific circumstance, but I would say the age of the child is dependent on what the child issue is. I know that there's in child-parent psychotherapy, for instance, there's a series of trainings going around to use telehealth with CPP, and if you're familiar with CPP, it's for 0 to 5. So I think the way that you would conceptualize your treatment different, though, is the younger the child is on telehealth, the more parent involvement is going to be needed. So it's going to be, and CPP is very parent heavy. It's pretty heavily focused on parenting and the parent-child relationship. So I find myself just altering treatment to focus more on parent-child dynamics and on parenting with the really young kids, unless they're old enough to do their own processing and learn coping skills. And if they're conducive to CBT, well, that CBT works very well with telehealth. Whether the child's appropriate or not for telehealth kind of depends on whether they're going to have parent support in the session and their own symptoms. So, if they're too hyper that they can't be still in front of the screen long enough to do an intervention, then they may not be appropriate for telehealth anyway, even with the parent there. So you may need to be meeting with the parents alone in that case. So.
And I definitely want to shift to that. We probably spend the last 10 minutes at least or so focusing on how to determine if a particular patient is appropriate for telehealth. But if we could stay with the confidentiality topic for a sec, I know that some people, like you're even noticing even on our webinar here, that some people have their headphones. So I know with some of, whether they're teens or young kids, if they can handle the telehealth session and they're appropriate for it, some of them feel more comfortable if they have their earphones, or I talk about, are you in a place where you can talk privately and in a confidential way? Sometimes even the parent, I've had one situation where the parent did come in the room and we just had to pause for a second to get to understand what was happening there. So I don't know if you all could speak to that, and not just children, but with the adults. How do you know and monitor for if somebody is eavesdropping, if they're standing outside of the door or in the air, but we can't see them, but how do you monitor for that just to make sure that it is a private situation?
I think it's really important to set the norm for telehealth in the beginning, just like you set the norm for how it works in your office in the beginning of treatment. So, in launching sessions with a child or adult, let's just say a family, through telehealth, if you started off asking about the setting, where are you located right now, what room of the house, who all is in there, and a lot of times the kids will even say, well, let me show you around, and they'll turn the camera and show you the room or the living room or whatever. So you're starting off kind of assessing that setting every time, and then you ask, is this a private setting? Are there other people listening? So you demonstrate that it's important and that you value their confidentiality, and kind of implying then that they should be valuing that too. And once that's happened 2 or 3 times, I think that the norm is pretty well set, and you just ask a couple of questions at that point.
Okay.
And I think also, just like what Adam said, is, almost like coping ahead. So saying, if someone were to walk in and we're talking about something that's not, something that you want them to hear about, or, we can end, or we can just pause for a minute and get them out of the room. Or I had someone just this week who is an adult who lives with their family but doesn't have a very good relationship with them, and towards the end of the session someone walked into the room and he went, and I just said, well, is this okay time to stop now? It looks like someone else is in the room. And he's like, yeah. And luckily we were at the end, but if we were in the middle, we might have ended, and then I would have called and checked in. So just recognizing that that's not something that's usually going to happen in your office. Someone's just going to walk in and you'll be like, but that is more of something that can happen while you're in telemedicine, and not just going on like business as usual. I mean, I had someone whose husband walked in, and for her that was just fine, and he was just walking through the room, so we just stood there for a second while he took the dog on, and they went out and he was aware of what was happening. And so that was a very different situation. So I think it's about being flexible and, you know, again, continuing that conversation. You know, if something happens unexpectedly and you haven't talked about it, just making sure that you address it either over the phone or next time, and just keep that conversation going. We can't, go ahead.
Sorry. Because a lot of times they don't know, and I think that's why it's so important to set the norm. I've had parents who set the computer on the counter in the kitchen and assumed that we were just going to do therapy in the kitchen, and the mom was like, you know, cooking or whatever, and was just going to listen in, no big deal. And so it's just, I think they just need a little bit of education sometimes.
Yeah.
I had somebody else who wanted to do a therapy session while they were driving down the road, so we decided to wait on that one.
Yeah. Well, I would agree with that, Adam, that setting the expectations up front and kind of, again, going back to that checklist is making sure you cover a lot of things. But that very first session you have with them, well, backing it up a little bit, when they call in, especially for new people or existing clients who are just doing telehealth for the first time, we have our staff do a little bit of training with them before we ever talk to them. And then that first session, going over the expectations, and that I think has worked pretty well for the most part. And people are do try to find a quiet place or whatever. But I've had the same thing where I had a mom I was seeing yesterday, and for her own individual therapy, and all of a sudden one of her adolescent kids' daughter came in crying over a poor grade she had gotten just then, and so she was like, came in crying, you know. So I was quiet while mom stopped and handled that and got her on her way. We've had cats on the keyboards, we've had dogs come in barking, etc. So you know, but it's also been interesting too, because many of these people that I've worked with for a long time, they'll talk about their animals, or they'll talk about, one woman has a project she's been working on in her backyard, and she took her camera and showed me that project, and introduced me to her dog and her cat. And I've met lots of animals that I've heard, you know, a lot of these are support animals or family members that they talk about. So now I get to get that introduction. So people have kind of liked doing that. So there has been, like Adam said earlier, it's like part of this, people find it intriguing and interesting, and it's kind of opened up some other aspects.
Yeah, I was thinking about that when we were.
Go ahead.
Sorry. I was just saying, I was thinking about that when we were talking about the intake and how we're losing some by not having them in person. I think we're also gaining some by seeing their house, by seeing their animals, by seeing how they interact differently in a different setting, by seeing that their daughter comes in crying and wants to be nurtured. You know, I mean, those important information to know about.
Right.
Yeah. So I feel like what you all are
I got to watch her in a real live moment.
Absolutely. So I feel like what you all are referencing are these individuals or situations where really it's working out well. You're able to kind of balance all the legal and ethical aspects of it, and actually getting some other kind of benefits that we may not get from the in-person sessions. How are you all determining if a particular client is appropriate for telehealth? Like, what are some situations where you all would say, you know what, this person is not appropriate?
Well, it's the same thing that we would do in the office. If it's not appropriate for them, there's probably a distinction there, but sometimes people aren't appropriate because they need a higher level of care. So, for example, we just sent somebody for inpatient substance abuse unit or inpatient substance abuse treatment. And so, you know, those things are still the case, but what happens, and I haven't had this happen yet, what happens with somebody who maybe they don't have access to care because of, you know, they're afraid to go someplace else into a hospital setting, and how do you help those people get the reassurance that they need? And I know this one person that we were sending, it got into, well, how do you go? Do you fly? because they were going out of state. Do you fly on a plane or do you drive? Which is safer? You know, do you stop at gas stations and then it's going to be you're exposed to filling up with gas, or do you get on a plane? So that got to be a real big debate about which is the safest way to go. But Adam, I mean, you may be able to speak with the appropriateness with kids a little bit more.
Yeah, I find myself, well, given the current COVID status, that it's really not an option for most to come into the office. I find myself adapting treatment more so than eliminating the option. But I did have a client just recently who was very hyper, and it was our first. I'd seen him in the clinic once, and then on telehealth, I couldn't talk to the mom about behavioral things because the child was so hyperactive. We couldn't even have a conversation, really. So that's going to, I think, an issue. You know, if there's not a child care available, then adapting the session by working with the parent may not even be an option. So I guess that's where I go with it, is how do you make it work right now? But if that wasn't the case, if coming to the clinic was an option, then yes, certainly there needs to be a certain level of behavioral regulation and emotional regulation in order to practice through telehealth. I would think also, Tisha, you may work more with severe mental illness, but I would also think that could be a problem also. And certainly certain levels of developmental delays would be, I mean, I think there's a certain technical capacity that's required to use telehealth. So.
Well,
Yeah,
I think it raises another question too. Go ahead, Tisha.
Oh, I'm sorry. I was just going to say that I agree very much with Adam that at this point, when you don't have much of a choice, it's more about adapting the types of treatment that you're doing to make it more of something that could be used over telehealth, at least in this temporary. So I do work with people with borderline personality disorder, and I do dialectical behavior therapy. And, you know, at this point, you know, a lot of times we are shifting into distress tolerance mode, and we're, you know, not making things worse, and we are using those skills and not necessarily pushing for a lot of behavior change or, you know, big hard things to do, but still using those opportunities to use skills and doing lots of skills coaching. So, you know, it's not that you can't do DBT, but you're not going to be doing the exact same kind. We talked on our DBT team in the VA about how, you know, some people are moving to shorter appointments just because an hour on the phone or even via tele is a little bit just too much for them. And so again, you know, the best thing that, you know, the DBT is much of an interpersonal thing, so it is more difficult, and definitely would prefer them being in the office with you, but you can adapt it. And, you know, I think it would be more detrimental for sure to just say, well, we can't do this with you right now because you're, you know, it's not appropriate. That would be not good. So just being adaptive. Outside of, you know, this, I think, yeah, I mean, we certainly would not, it's important to encourage coming in and regular sessions and making the effort to come to appointments, because that's a big part of the behavior change, and not coming to appointments can be an avoidance strategy, even if it's via tele or on the phone. You know, if this wasn't a national pandemic, then we, you know, I certainly would, for a lot of the people that I work with, especially with DBT, I would, you know, be telling them, nope, you got to come in. I know it's easier, but I want to look at your face here and with me. You know, I think it's very much about what's the best thing therapeutically, and, you know, working within the parameters that we have.
Well, here's another dilemma that some people may or may not face, but we did in our office. We were doing primarily telehealth. After a couple of weeks, most people were switched to that, but we had just a handful of clients that were still coming in, but where people, there was a office in our building where someone had tested positive, and then one of our staff had been exposed. And so we ended up closing our clinic to actually having people come in at that point, and went 100% telehealth. So that one example that I told you earlier, where we had one person who, there was a little snafu with the informed consent, that was somebody who was more appropriate to be seen in person, and the plan was for that person to be seen in the clinic. But once we decided we needed to close our clinic to people coming in for 2 weeks, then what do you do with that person? So we had to adapt, and that person agreed to be seen or by telephone. But again, there was a delusional aspect to that client, and mistrust of video and recordings and fears of that. So that person was comfortable doing telephone. Was it the best solution? That would probably been better to see that person face to face, but it wasn't an option. So doing it by phone was, you know, an adaptation. And that may be something that people need to think about, is you never know when your clinic might get closed, even if you're still seeing people. So you need to be prepared for that. I know of another clinic, not a mental health clinic, but you know, another healthcare outpatient clinic that got shut down because of a staff person had tested positive. And so the health department will shut you down if you don't shut yourself down, if somebody has been exposed within your clinic. So you need to be thinking about that, and what the being prepared. So we had, for the most part, we had been talking to people already. By the time that happened, most people knew that they had the option of telehealth. The few people who were still coming in had actually already signed paper consent forms in the event that we did go telehealth, except for that one patient, and she had refused to sign it because she didn't want to do it. But then when it was the only option, then she said, okay, I'll do it by phone.
Mm-hmm. Yeah, I appreciate each of you all panelists kind of drawing a distinction between what we're doing right now and how it's a lot of adapting going on because of the situation, and how it's not another option. So I want to connect that with a question that was asked earlier around the practical implications and specifics of the governor's emergency proclamation of relaxing the HIPAA violations when done in good faith. So I think that's connected with what we're talking about, this idea that some parameters are being relaxed right now. And so people are kind of entering telehealth in this relaxed culture. So what is it going to look like? What are some practical implications of that when some of this relaxing is not so relaxed anymore? And so anyway, so that's the question about that from a legal and ethical standpoint. What are some and this will be our last question before the break, by the way, for the panelists and attendees. We'll do this question then break. Yeah, so if you all could address that, the practical implications of the relaxing that's going on with HIPAA violations specifically was the question, but just in general, what do you think about that?
Well, maybe we should clarify what the OCR change was first. And I'll give you my understanding of it, and y'all feel free to chime in. But my understanding was that the OCR made it so that we could see, which is the Office of Civil Rights, relaxed the HIPAA enforcement of the use of HIPAA compliant telehealth software, which meant that people could technically use, or they weren't going to be enforcing the use the law around things like FaceTime and Skype and things that we typically would not be using because they're not HIPAA compliant. So they were saying healthcare workers can help their clients, and they're not going to enforce the law around the level of encryption. But I don't think I've talked to anybody who's done that. The HIPAA compliant versions of these softwares are so available. There's no reason to do that, in my opinion. We have
Right.
Zoom and DoxyMe and Simple Practice. I mean, there's tons of, and gosh, there's probably 10 others. But that was the law. Is that correct, Joyce?
The OCR relaxing the guidelines, I think you've got that right. But we don't know when that, when all the relaxations are going to go away. So you've got what OCR did in terms of HIPAA compliance with technology. And I tend to agree with Adam. There's really options out there. So this is the time to get educated and figure out what those things are during this relaxed time. Don't just stop because it's relaxed and not research those other things. So if you're using FaceTime now, don't assume that you can continue to use FaceTime. So you need to be doing the research and figuring out what platform you're going to use so that it will be HIPAA compliant when the relaxation goes away and the enforcements come back. The other part is that the governor relaxed the telemedicine law through executive order. That will go away someday. So, so just because things are relaxed now, we don't know how much time that's going to give us. We don't know if that's a month. Is it 2 months? Is it 6 months? Is it a year? I don't know. So just be preparing for them to go away at some point. And I think that is why it's important to do as much telepsychology, telehealth, telemedicine training as you can, so that you're prepared when these relaxations go away.
You could say the same for the insurance coverage of telehealth too. They've made a lot of policies have changed to cover telehealth right now that weren't covering it before. My personal hope is that the law and the insurance changes will be permanent, that we'll be able to do intake in telehealth, that they're all going to pay for counseling and for intakes on telehealth the way that they are now. But that's not permanent at the moment. So we all have to watch those dates as we practice.
Right. And I think Blue Cross Blue Shield, when they said that they would do this, they said till May 15th. I'm like you, Adam, I'm hoping that they will extend that. But right now it's just till May 15th. So it remains to be seen how long these will last. I would assume that as a result of all of this, that insurance companies will be reconsidering what their policies will be. But also, I would assume that there's going to be potential legislation, perhaps in Arkansas. There might be, I don't know this, but it makes me wonder if there might not be some revisions in the next legislature to the Telemedicine Act. So I don't know those things, but there are things to watch for. And ArPA has a very active legislative group that Tisha is involved with. So I would anticipate that you guys are going to be seeing things around that. And I know the SIPAC is probably going to be coming up and likely to be proposed for legislature about practicing across state lines. So regardless of which profession you're in, get with your professional association to whatever your legislative groups are, to be at the table and talk about these things as they come up.
Right. I definitely appreciate you all addressing that, because I know I've just heard anecdotally a lot of people saying that this is not going to go away. Like even after everything, we're able to kind of go back out in public and everything opens back up, it's really going to be hard. Some people are going to want to continue telehealth as possible. So we're really just going to have to, like, our practice of psychology and of mental health treatment is just probably changing going forward with what's happening.
Right.
Joyce, if you don't mind,
well,
this is the last, go ahead.
An important thing that Medicare relaxed was the place of service. And, being able to be seen in the home now is a new thing. There was supposed to be, even though you did telehealth, it had to be at a certain location on the other end. And there are all these rules and requirements. So that's going to be important to see if Medicare continues to allow the in-home sessions to continue or not. And because I know the majority of people I'm seeing, they're at home. Some people are at their offices. but they're not in clinics someplace else, or they're not in an office someplace else that's proctored. So that'll be interesting to see how that all evolves.
Right. There's going to be a lot of things to track. This is just the last thing here. I'm sure this will be quick. Joyce, if you don't mind, we may have had some people to join on. If you don't mind reiterating your point about our statement of intent as psychologists, somebody just had a quick note about that and how we might have to revise that. If you don't mind restating your point about the 120 days and just where that is and what psychologists need to do.
Okay, there was a emergency legislation that was passed last March, I believe March 17th at noon, I think was when it went into effect at the last board meeting. And the legislature passed it, so they notified us at noon at the board meeting last month. So you can go on the website and read that. And so part of that rule is that you have to have documented training in telehealth. So it has to be part of your scope of practice, and you'll need to complete a new updated statement of intent to show telehealth is within your scope of practice. But what the board did is they waived the training time for 120 days. So you don't have to have that training documented with the board for 120 days. So you've got some leeway there. Again, there are tons of free trainings that are out there right now. So there is no reason not to get the training. And it's the expectation is that you know what for psychologists, you know what the APA psychology guidelines are, that you know what the Arkansas Telemedicine Act law says, and that you get training, that you have 120 days from March 17th, I think, to get that done.
And is it a certain number of CEs that would be needed for that? Like, do you just have to say, even if it's 1 hour, is that okay? Or does it have to be a certain number?
I don't think it was specified as a certain number, you know, but it has to be sufficient. So we'll look at what the board will look at what's presented and decide if it's sufficient. So that's sufficiently great. But, you know, if you said, well, you know, I sat down with Adam Benton for an hour and talked about it, that might not fly, you know. So even though Adam is an expert in this, but to have something that has some credibility behind it, and really you want this training. You want to know what all these glitches are that can happen. You've got to be up on, do you know about the technology? What about all these practical things? Are you familiar with, you know, do you have a plan? If there is an emergency, what do you do? What arrangements do you have? If you're doing telehealth and you're in Little Rock and somebody is in Lake Village, Arkansas, well, what is your arrangement in an emergency situation? Do you know, do you have names of family? Do you know what the emergency personnel are there? Is there, do you know their doctor? What, you know, you have to document something that if things go awry and there's an emergency. So those are kind of practical things that trainings will cover. So I don't have an exact number for you, but
okay.
You know,
so it's not
people
any,
are
but
here
it sounds
today.
like those would be the types of things that would be ideal to include in it, and to show that it
Right.
was sufficiently, like, certain very high priority topics were covered in the training. How would people go about updating their statement of intent? Is that, I know Tisha, I think you posted the you posted a link. So I'm wondering, is that clear? Did somebody ask a question? Do we need our original one, or is the board going to send out information? What's the process?
You can go on the website and find a statement of intent under forms. So there's a form tab, and you just find it and download it and fill it out and turn it in. You have to update a new one. One of the important things that you need to remember to do is you've got your old statement of intent that will have all the areas that you're that you've shown that you're competent to practice in, either independently or under supervision. you've got to make sure you transfer those onto the new statement of intent along with the telepsychology. You don't just do one statement of intent with telepsychology. It's a totally updated statement of intent.
Okay, so completely updated, is under forms on the website. Somebody else noted that maybe we need to send in a cover letter as well. Would that be the form, the cover letter?
Yeah, you
okay.
know, just saying, here's my new statement of intent, and here are my documents showing where I've got telehealth training.
Okay.
And I see the question here is, how do you get your original statement of intent? If you don't have a copy of it, just contact the office and they should be able to get one to you from your file.
Okay, and somebody's saying that Brandy Thompson can scan and email it to you as well. So I guess that's what you're saying about contacting the office.
Yeah,
Yeah.
right. Yeah,
Somebody
Brandy is on staff.
Brandy is who? Mm-hmm.
Brandy is on staff at the psychology board.
Okay.
We're talking about the board and referring to the psychology board. So the counselors
The psychology board
have their own,
yeah.
have their own requirements.
Yeah.
Yes.
And social work would have their own requirements, et cetera. So when we're referring to these, we're talking about the psychology board, but each board will have their own rules and regulations and what you will have to do. So what we're saying about this, yeah, what we're saying about this is psychologist specific, psychology specific, psychology board specific. Yeah. So go to your own board if you're licensed by a different board.
Some of the places to get trainings, the Telebehavioral Health Institute has a really good training. Theirs is, they charge for it. PESI has a really good training that was free with the code. There's a code for it out there. It's Tell Us Something. If somebody remembers it, you might chat it. But it was a 12-hour training for free. I did that one recently just to refresh and thought it was a good one. And then APA has a 6-hour training that's also free that they're putting out.
Okay, awesome. And when we do fill it out online, somebody is asking, is it just an other box, or is it something specifically on there for telehealth, or does this just go into other?
I can't remember if it's been updated to add or not.
Okay.
If it's not on there, you just add it with the other.
Okay, and as people, I know, I think multiple questions came in on this one before our break here, but would it be okay, Joyce? I know the board, of course, couldn't pre-approve and say this particular thing will count and give it a thumbs up, but can people say that they did this particular training and add that as they apply to update their statement of intent?
Oh, yeah, this one?
Yes, people asked about would this one kind of count?
I can't speak for the board because it's a group decision, but I would think that this would meet the criteria. So Khiela, this one is got CE credits, right?
Correct. It's 3 CEs.
Yeah. So as long as you have your certificate, you know, send that along. And that was part of the reason of designing it this way is, you know, legal, ethical, and practical implications is that it's so timely.
Okay, excellent. Thank you, Joyce. Some people said that the PESI training, that the discount code is tele-free, but and it might be expired as well. So if you want to try it, then it's TELE free. And then also just a heads up that it might be an expired code. But thank you, panelists, for this first kind of section of our webinar. So what we're going to go ahead and do is take a break. Let's take a break to about 2:20 or so. They'll give us 7 or 8 minutes just to break. And then we're going to transition over into some of the practical considerations for implementation. We already talked some about it, but we're going to do a deeper dive into that. So let's come back at about 2:20.
Thank you.
All right, thank you.
We moved around a little bit. Do you know what the rule is, Adam, for like who gets to be where in the squares? Oh, sure. You're muted.
No, I don't know the rule, but it'd be interesting to know that.
It's, I don't know. We just moved around. I was like, on my screen at least.
Yeah, mine too.
I was on a meeting last night with APA with the leadership fellowship, and there's like 15 of us. And so it was, and everybody's was in a different order. So I just wonder what the algorithm is.
Were y'all using Zoom, I guess?
Yes.
Have you tried Google Meet?
I haven't.
I
Is it
used
better?
No, I thought it would be better than it is. I used it the other day when somebody couldn't do Zoom for technical reasons. It worked, but it didn't work as well.
I did my first DoxyMe phone today, and it was pretty neat. I have a veteran that can't figure out BBC, and he wanted to do FaceTime, and I thought, I have the DoxyMe, and I thought, well, I mean, we can do anything pretty much right now at the VA, just like anybody else, but I was like, well, DoxyMe should be better as far as compliance, and also he might be able to figure that one out. And it was pretty easy. It just sends them a link, and they just click on it, and it's.
A lot of people seem to like it, but I've heard some complaints too about the stability. I don't hear that with Zoom.
Yeah.
All right.
I think we're about to get Zoom pulled out from under us at the VA.
Oh, no.
Because of the security questions?
Yeah.
Okay.
At least that's what I hear from on high.
Well, I think we're going to get back started here in just a sec. Let me just do some announcements for those who may have joined after we started in the beginning. So this webinar is being recorded, and it will be uploaded to our website so people can view it at a later time for people who either just want to view it again or who were not able to join us today. And you all may notice as attendees that you're able to put some questions in our webinar chat as we move through. If you have any questions, I am monitoring that so our panelists can address your questions. So just to wrap up a last point, somebody noted that Telepsychology Best Practices 101 has a series that's free in its HCEs. So as we mentioned in the last segment, there are several free and then some that are available at a low cost telehealth webinars that are out there that can be very helpful. So we encourage you all to look into that. All right, so let's jump into this next segment. So what we're going to talk about now in this segment is more on implementation. So we've talked some about that and how we're conducting the sessions, but if we could specifically for a little bit focus some on assessment and testing and how people out there are thinking about that, and whether it's different when we think about neuropsychological testing. But we know that a lot of our colleagues, a lot of our psychology professionals, that may be a good bit of their caseload would be assessment. So it's really something to think about right now for people where that could be half, if not more, of their revenue. So Joyce, I know that that's something that I might ask you to get us started with that, because I know you said you have looked into that and you have to consider that for your practice.
Right. So, so we do psychological and neuropsychological testing in our clinic, and so there's a lot of things to think about with that. And just along the lines of getting training. So for example, the 101 series that's being offered is excellent. But one of the things to think about with some of the webinars that have been out for a little while, some new trainings that are being put on now take into account the COVID crisis and the pandemic. So that's one of the things to think about as well. Some of these trainings we do might have been produced prior to the pandemic. So this adds a whole new layer. One of the big issues is basically from a basic health standpoint. You know, when you do testing, if you're doing a WACE, you know, and using blocks, you're up close and personal, you're touching things. If patients are handling papers, they're taking tests on the computer, they've got their hand on the mouse, their keyboards, you know, so there's all these different stimuli and computers, et cetera, that we're using. And I'm sure that all of you are like me. It's like you start seeing where those fingers go and people's touching their faces and sneezing, et cetera. Takes on a whole new meaning right now. So as this was first starting and before it was kind of sinking in, we were still doing testing. And then we started thinking, you know, it's like, at first it was like focusing on, you know, keeping everything sanitary, wiping things down and, you know, all of that. But then at some point we decided we just don't do it. So while we're in the midst of this pandemic, what do you do face to face and when do you go back to it? I ended up taking a call from the head of infectious disease yesterday, and you know, they're wanting to know it's task force that's working, what kind of work we do. And so what I learned is that we're probably going to have some protocols or some guidance that comes out. Much like, I don't know if any of you have, hopefully you've seen the suggestions that are on the psychology website that came from the health department on April 1st. But it's got all these different recommendations about how to clean your offices and how to do your waiting rooms and don't have magazines in the waiting room, etc. So we were talking about that hopefully that some of that guidance will be given to us from the health department about what are the best practices when people do start opening up. So for right now, we're not doing testing in person. And we'll have to decide when to do that and how to do it. So in our clinic, we're looking at what procedures do we want to have in place. And, you know, the things that we're thinking about, I'm sure will be things that will come down as those recommendations from the health department, and we'll meet somewhere and have some new guidelines within our clinic when we do start testing again. But right now we're not doing it in person. So that brings up the question about, well, what about doing testing by telehealth? So there are a lot of questions about that as well. So one of the questions obviously is about test security. You know, that how do you do that? And how do you know that they're not recording it or taking a picture of the stimulus? How do you know that they're not using their phone to look up answers? Or how do you know that there's not a person sitting on the other side of the screen or over to the side feeding them answers? So, so there are a lot of questions like that. So I did a training that was put out, and this one will be on the website, but the National Register did one. It's called Risk Management for Teleneuropsychology, and it was a very good webinar. And one of the things they pointed out is that there's the issue of standardization and administration. So if you administer a test in a non-standard way, what does that mean? Well, there is a little bit, just a little bit of research in telepsychology of using certain tests, but the numbers are low. So they're lacking norms right now for doing that. but people are doing it. So when you do that, is choosing some of the, and I don't have it in front of me, but obviously some of the verbal tests are, you know, that have had a little bit of the research done on it are better. Drawing things, or when you're having to demonstrate things, yeah, obviously you can't do blocks, you know, in the same way that you do in the clinic. So it's just such a nascent field, the tele assessment. However, one of the presenters talked about that we really are assessing in many different ways. So kind of the practical advice was use your clinical skills, use your assessment skills, doing a good mental status exam, various different things that you do in the clinical interview, and reviewing the records. We can do that. But then having more of an abbreviated battery of tests. And so one example that was given was review of the records and that kind of more abbreviated screening, really screening type tools, and clinical interview, and being able to feel reasonably confident that the issue was not a dementia. This was a patient who had several different medical factors that really explain the symptoms more, but really saw it as more of a screening. So later, then maybe after a screening, if you're recommending more in-depth testing, that might be something that can be scheduled later, hopefully when we get back to normal. The one area that was cautioned against strongly is do not do anything forensic through telehealth. You know, basically it's sort of a risk management, and I forget the name of the presenter who's a forensic psychologist. He said, I don't want to be sitting on a stand and they saying, so how did you do this test, and was that standard? And you know, being able to defend that, and there's no research behind it. So the advice was to really be careful about that. Now, obviously, there may potentially be something that's life-threatening that might have to have a decision, and so there might be some argument for doing it, but it was strongly cautioned against the forensic types of cases. As they said, the high stakes assessments that you would be using unvalidated methods. So they were really advising against that.
Yeah, Joyce, if I could just insert something. Thank you for addressing that. That was a specific question that somebody had around forensic issues. So thank you for clearly addressing that. And someone said that Dan
Yes.
Taub was the presenter. I don't know if that's a familiar name, but Dan Taub, does that sound?
Yes.
Yeah.
That's
so,
right.
And I think he came here
Thank
to
you.
present before.
Thank you, Kristen.
Thanks, Kristen. Yeah. So I think he came here to present before. I think he presents with, he's one of the representatives of the trust. I think he came here to present in Arkansas not too long ago. So he's very knowledgeable regarding these issues. But thanks for addressing the forensic issue, Joyce. Okay, go ahead.
Yeah. I say, you know, for our clinic,
So,
we did testing also, and had to reschedule many of the testing appointments that we had. But because we weren't prepared, I feel like there's a lot of tests that can be done online or can be converted to online administration if you have ample time in advance to do that. But just in looking at Pearson, for instance, Q Global has like 60 different tests that can be online administered. Only a handful of those do we use in our clinic, but I think there's maybe more opportunity there than what I've had experience with. Joyce, have you used any of the Q Global, specifically the IQ testing?
no, we've done some of the, and I forget which ones they were, but we've done some of the questionnaires, like to send to teachers for I forget which ones they are. I don't remember if it was the Basque or what, but we've had some where we emailed in ADHD evaluations, for example, but we've not done the any of the other like main tests. That was one of the other things that was brought up about using non-standard test administration, and the example was for accommodations or IEPs is, and this is kind of a legal ethical thing, is when you do provide those services, if you decide to provide those services, you need to let them know and let them choose. We can do it this way, but we don't know whether it'll be accepted. So, you know, we don't get to decide that if it's whoever is deciding, like, do you get accommodations for the ACT test? Well, if you had a non-standard administration, or do you get accommodations in school? You would hope so, but we don't know that. So there is some risk that if people decide to do it by telehealth, that some decision maker down the way, besides outside of forensic, might say, well, we won't accept that. I think we are probably going to go into a new phase where it probably will be accepted. I would think it makes practical sense, but we're not there yet. It's all new.
Absolutely. If you could speak to this, it was a specific question that somebody emailed in, and I don't know if this falls within Pearson, if this is the company that produces this test, but the Vineland, somebody specifically wondered about the Vineland and doing that via telehealth. Maybe Adam, I don't know if you could speak, or others could.
Yeah, I think the Vineland is a Q Global Pearson test. Just like in this list I'm looking at now online. I mean, there's lots of the Milan, the MPI, the Bex. Lots of personality tests can be done digitally and scored like immediately. But that's where you get into the issue that Joyce was talking about. If you're going to be testifying to those results, you can't prove that they did it alone. But if it's for clinical use, then that might be an option for you if you prepared. It looks like Dr. Salhever said that Q Global for IQ tests requires an administrator and an iPad. I don't know if that means that the patient has to have their own iPad and they could be at home, or if they would have to be in person. Maybe he'll respond to that.
Well, Dr. Salhever, do they require a proctor? Is that what you mean by an administrator? So there's, you know, that's the other thing, you know, again, going back to sort of the Medicare relaxing their rules, and, you know, some of these situations, there may be someone on the other end where I might be in Little Rock administering a test through Q Global in, say, Dumas, Arkansas, but where are they? Are they at home with their parents, or are they in an office somewhere with a proctor?
Yeah, right. And then you have the question somebody brought up of, is insurance going to pay for testing that's done online? And how would you bill it? I don't know that you could bill that as a counseling session if you're doing testing.
That's definitely not one of the things that's on Blue Cross's list right now. And of course, they don't pay very well for testing to start with. And what we're seeing is that they're paying less for therapy sessions than they do in person. So I would imagine if they did pay for testing, if it's even less, that's kind of problematic.
Yeah, well, we probably should be careful. We'll get into a lot of billing discussion on this, but
that's real sticky.
Yeah, I fear that's where this will go, though. Is it's less expensive to provide telehealth services. So hopefully that doesn't reduce the price over time.
Yeah, so I see that Gary did respond with the iPad shows samples and responses that are mirrored on the administrator's iPad. So, okay.
I'll say that just through the VA and in primary care, we do we have kind of an initiative of measurement-based care. So we do a lot of screening And we are definitely working towards ways to do screening, like doing things like the PHQ-9 and the G87 and the Audit C, and different things to make sure that we're looking at things changes over time. And you know, we have lots of clinicians that have been administering those over the telephone for a long time. So having you know, the points and asking the questions. But again, it's clinically used, and you know, the emphasis, especially now that we're not seeing people in person, is on really using the questions and the scores as information to see, you know, to look at changes over time, but not necessarily for diagnostic purposes, and really recognizing that that's not really how those measures were designed.
Mhm. So it sounds like we're saying being very thoughtful about the intended use or what the referral question is, and let that really factor in some systematic thinking and decision making about whether to move forward or even how to do that.
I will
yeah.
say that there are some like apps, so like some of the VA apps that have things like the PCL on them and the PHQ-9. And again, if you're using them clinically and they're not physically in front of you and they have the app, they could have the questions and you could have them do that and give you the score, and you could use that clinically to talk about, you know, things that might have changed over a few weeks or a month or something. So, you know, there are kind of, or mailing them we'll mail them the blank one, and then when we're seeing them, they can they can look at the questions and tell you, and then you can score it. And so I think there's some ways to use things clinically in an innovative way. But again, you know, if you're doing it for forensics or for really, you know, needing to get an accurate diagnosis, there are definitely challenges.
Yeah, almost as if we're needing the norms, like the normative data. If that's essential, then maybe that should be in person.
Mm-hmm.
Whereas assessing more clinically might be okay.
Yeah, or if there's a question as to whether, you know, motivation or, you know, there's other kinds of secondary gain or consequences, then that's really something that's a concern.
Mm-hmm. So it seems like it's really important to be really clear and distinguish between, so Gary kind of noted, which is a good point, of distinguishing between testing and assessment and the highly technical nature of testing and how that's different if we're talking about questionnaires or clinical interviews and so forth, and how to kind of look at that. So I appreciate you all kind of making those distinctions. If it is more of something that's not necessarily, because Tisha, it seems like maybe what you're talking about a little bit is looking at clinical outcomes and using clinically within the context of therapy versus something really set aside as a assessment, you know, really something a touch more comprehensive and has a different reason for doing it. So if it really was the idea of somebody is trying to approach this and somehow has concluded that this is okay to do via telehealth, and they are writing a report, how are you all thinking about that? I don't know if Joyce, you want to refer to that kind of, so or anybody who wants to think about this. How are you all documenting that this was done via telehealth in the report? How are you looking at that?
You have to, it's part of the condition. So, and also that was one of the things out of the training I attended. It said it must be in your informed consent that if you're using teleneuropsychology, which I would assume would apply to, you know, psychological testing as well, that you have to state in your statement of intent that it may be more limited, because it's not the standard way of doing things. And so that was one of the points. If just like when you're in the clinic, if something happens, if a computer breaks or in the middle and a test is compromised, or you don't get a subset because something went wrong technically in the office, or if something happened with a patient and they fell asleep during a test or something, you write that up in the report as the observations. So you just have to have enough in the report so you know what transpired and how it was done. So if you're going to do tele-testing, you've got to say that you did that and comment that it might be limited. for those reasons. A few other things that was talked about was just kind of some practical things is, you know, thinking about the impact on validity, reliability of a measure if you're doing telehealth, and you know, that's just always a consideration. Also, in terms of deciding whether to do it or not, just like, does it need to be done now or can it wait to when you can do it in person? Get the advice, which is just really good for any part of clinical practice, is talk to other people, you know, consult with other people. How are you doing it? What do you think about this idea, etc. So get some of your, you know, like Dr. Salheeb or Dr. Benton, you know, get together and kind of run your ideas by each other. It's like, what I think might be a good idea, somebody else sees a hole in it. So, you know, that's very valuable. Document the suitability for the patient to, you know, why is it that telehealth is suitable for this patient? So give your rationale for that. And the other caveat that was put out there about informed consent is that, you know, your informed consent will not protect you if you fall below standards of care. So, you know, think about standards of care and be clear about that. And he said, don't conflate an emergency situation with decreasing standard of care. So those were just a few things from there. I am trying to figure it out. The other issue, and I don't know if any of you are on listservs that this is going on, but there's been rather heated discussions about doing testing versus not doing testing, and when you do it, and what's an emergent situation, etc. And in the current healthcare crisis, you know, what is an emergency? Why do you have to do testing? Why can't it wait? So I think you have to have a really good justification for doing testing in person right now. And I think you likewise have to have a good justification for doing it if you do some sort of high stakes sort of assessment for doing it telehealth. So thinking about that, and so there's a lot of things to think about just from a health standpoint. So the question then is, well, when is it okay to start testing again? So we're not testing right now in the clinic. Adam, I think you're not. So three things that they said was, one, when the government clears us, that it's safe to go back. You know, that's number one. And two, think about the patient's vulnerability. So if you're testing, so like I've got a patient of mine right now who is a cancer survivor and is still on some chemo treatments and is immunocompromised. Well, do you want that person coming out, coming to your office, getting on your elevator, walking, using the bathroom, etc.? So think about your patient vulnerability. And the third thing they said is think about your own vulnerability as an individual and your family, because if you're, you know, if you're providing these services, you're vulnerable, and then you go home to your family. So serious things to think about. So, you know, I'm looking forward to what the guidance comes down from the health department in terms of best practices when you go back to testing. We'll go back at some day. The pandemic will be over, but I bet we'll all be thinking about how clean are, you know, all the different things that we do. So I think those guidelines will help us even beyond this in terms of how we do things and being more mindful.
Absolutely. Thank you all for that rich conversation regarding assessment. And I'll keep an eye out in our chat if anybody has any questions regarding assessment, testing, psychological evaluation, however you want it, but that domain of conversation. If we could shift a little bit to thinking about still implementation, but thinking some about any cultural considerations. So I don't know if in you all's practice, and even if we could think about our demographic here in Arkansas, how it's different across the state, how COVID is affecting different parts of the state in different ways. We know Pulaski County, Jefferson County, and I think it's a few others that's been impacted a little bit more. But how are you all thinking about that? Clients that have different access to technology, maybe they don't have the bandwidth, or they just don't have the technology that could withstand a Zoom meeting, or maybe they don't even have Wi-Fi, or whatever the different variables are. How are you all addressing that? Have you run into that?
Seems like to me it goes back to having to adapt to this crisis that we're in and be flexible as providers. That's certainly what our patients are having to do too. I would even add to kind of the list of variables there, access to privacy, where they can have a private session. I think that is can be an issue. I do think I appreciate that some of the platforms like Zoom can run on the cell phone and cell data. I know that for some of my patients, that's made it possible and given them access to therapy that they wouldn't have had because they don't have Wi-Fi. But I also think another sort of cultural thing is just that because COVID is affecting different areas of the state in different ways. I think there's different levels of anxiety and different levels of need amongst patients groups in those areas. At least that's what I'm seeing with some of the kids that are coming in.
I'll say we've definitely had this experience, especially at the VA. We pretty much serve the entire state, and I work within primary care, so we have a very wide range of veterans that we serve, and also a wide age range. So I have veterans in their 80s and 90s. I have veterans in their 20s. Definitely, for some of our older veterans, they prefer telephone, and they don't have smartphones, and they're not interested in having smartphones. I do have some that are very tech savvy, so I'm certainly not going to rule them out. So I do a lot of telephone, and not able to do the more video platforms. Also, I've had the experience of veterans who actually can do the video, but once we get on to the video, their connection is so poor that it's really, the quality is just not good enough to be able to do anything meaningful. And so having to switch over to telephone after we've gotten connected. So there's, I think it's really important to think about their knowledge. We're very fortunate here at the VA is that we have like a vocational rehab, and we have people who will call them and talk to them and teach them how to use the platforms and get them set up. So we've got a lot of resources available. We've also got programs where the VA will send them an iPad. So for those of you who are veterans or have veterans who are in your families, let them know that we are really reaching out and trying our best to be able to connect with them. But I do think that always being able to switch over to a telephone is really important, and letting them know that, hey, if we get disconnected, I'll call you, or telephone is an option. I know that as far as billing and things goes, telephone is not as preferred, but I do think that especially in Arkansas, it's something that we have to really consider, because there are a lot. My sister and my mom live 15 minutes outside of Jonesboro, and they have zero Wi-Fi, and their cell service is really, really bad. Like there's no way they could do it. Right. And they're tech savvy people. My brother-in-law works for Social Security, and he's having to go to his church to work from home because they don't have Wi-Fi. Yeah. So it's even people who are very, tech savvy and would normally be able to do it, our infrastructure is not set up for this. So.
Right.
And I think
Yeah, we have,
socioeconomically too, right? People who can be able, I have veterans who can't afford to have the minutes, you know, the cell minutes on their phone that it's going to take to be able to do something like that, even telephone. So, you know, really thinking about the cost for them.
Right. Yeah, we had somebody that we did testing with and had finished it, and then all of this started happening before we did the feedback session. And so we were going to try to set that person up to do Zoom or whatever. And they said, "Oh, I don't have an email." So he just doesn't use it. And so it's probably going to be either phone or wait till it can be in person again. So, you know, one of the other areas that I think is important, and you just think about the wear and tear that all this is having on everyone, all of us, everyone, about this is just, we've all had to adapt. And so it's a stressful time for everyone. But if you think about like domestic violence and child abuse, you know, families that being at home together a lot more makes that a riskier situation. So that's an area of concern. And back to the privacy. So if you've got someone who's in a domestic violence situation and they're trying to have a therapy session, but you know, their abuser doesn't want them to do that, or they walk in and see it and get mad at them, you know. So, and it's a lot of things to think about.
Yeah, there's certainly a lot of groups of people who are more vulnerable right now.
Mm-hmm.
I'm glad you brought up children, Joyce. Certainly, there's a lot of kids right now who aren't being or don't have access to school, so they're not reports that aren't being made, and they're being exposed to a lot of things that maybe they wouldn't have otherwise. So.
Right. Another area. Go ahead, Khiela.
Well, I was just going to kind of summarize that piece. I'm glad you all are bringing up the vulnerable populations, and hopefully, you know, as providers, we can think about what that means, even here specifically in Arkansas, in terms of what we know about the type of adverse childhood experiences that are really common and really a major issue here in our state. And all the more reason I want to connect this back to something we discussed earlier in terms of the importance of really trying to make it work if possible within these legal, ethical, and kind of practical parameters, really make it work so we can still, at the very least, have some sort of contact with these families and populations that are vulnerable and at risk for really tough situations. So I'm glad we're talking about it in that way. So that's what I wanted. I just wanted to highlight that, and also highlight, Tisha, your point, because that was a question I was going to ask about the fees that are incurred, and are just being mindful of that with when it comes to Wi-Fi, their minutes, their data, and all of that, to know and to make sure they realize, you know, and be mindful of whatever plans they have or do not have, and how this can lead to some increased fees for them, and just to be mindful of that for them. So thanks for mentioning that, Tisha. Joyce, I think you were going to add something there.
We do a lot of work with people who are in recovery, alcohol or drug addiction. And so those folks went to AA. And so AAs have moved to Zoom for the most part now, I think. So that's been interesting to watch that whole process. So it's been just like we're seeing here, as we're talking about, it's like there's some downsides, but there's also some upsides too, in terms of people have more access to meetings, like maybe their work schedule conflicted with the time schedule of an AA meeting, but now they can go anywhere, and some people are like going to meetings across the world. They may be going to a meeting in, you know, London or, you know, Australia or whatever. So they're getting a little more diverse experience, which they've found useful. But, you know, some people are under monitoring for licensing boards, et cetera. So they're still having to get out and go get their drug screens, or getting set up with a, I forget the name of the breathalyzer, SoberLink. That's being used a little bit more now, I think. but you know, there's some people like early in recovery that being isolated is not good, even if they've got the access, and you know, their support system may have shrunk some, or they're isolated at home by themselves, and you know, there are risk factors there in terms of relapse. So there's just a lot going on and a lot of things to think about.
You're muted.
I'm sorry, I was
You're
on mute. Yeah. Okay, I'm unmuted now. Okay, can you all hear me? Yeah. Okay, so related to that, I feel like what we're kind of shifting to now is thinking about just the experiences that our patients, their families, particularly here in Arkansas, what they may be experiencing, and how this pandemic really is a collective trauma that we're all sorting through. So can you all kind of talk some, and I'm going to try to make this question specific to implementation, but still related to that, is what are some creative kind of ideas that you all are doing? Because just like you said, Joyce, this is creating some opportunities in some ways for these other kind of creative ways for us to engage with our patients. So I may ask Adam, if you don't mind, because I've heard you already say a few things, but yeah, wearing our mask. But Adam, what do you think in terms of the technology and telehealth? What are some creative ways that you've engaged kids and even their families by the use of technology and the telehealth platform?
Oh gosh, I think there's lots of things. You know, switching over to telehealth as much as we are now reminds me of the first time that I ever did school-based counseling, and I walked in and I felt like, what am I going to do here? Like, I'm meeting with this kid in a cafeteria. I have no tools. So, and then the more I did it, the more I realized there's some tools. There's things that I can do in the environment, or there's things I can bring. And then over time, the toolbox kind of grows. I feel the same with telehealth. Like there's always things in their environment that we can use. You know, some specific things, for instance, I think having the ability to see their home opens lots of doors. Specifically for kids, we've talked about pets a little bit already, but kids really love having their pet present in a therapy session. You know, a cat sitting on their lap and petting the cat while they're talking about difficult things is relaxing and soothing, and they love to share about their animals. Being able to see their room, the things that they take pride in, I think generates lots of discussions. I think with like parenting, for instance, seeing parents and kids in their own home and how they interact certainly opens some privacy. I'm hearing an echo. Are y'all hearing that?
Mm-hmm. It's Joyce.
Got it. Okay. There we go. So I think those are some things too. Also on Zoom, some of the things that I really like to do, you can share your screen, you can use a whiteboard, you can change your background. And so I'm approaching a lot of telehealth with kind of a toolbox of creative things I'll do just to help engage kids. Another one that I really like to think about is just physical movement. So kids, especially really anxious kids, it helps to get up and move around and stretch or do yoga or take deep breaths and just kind of walk around their room and just things like that. Does that kind of answer your question?
Yeah, absolutely. Yeah. Okay. So, and what about, go ahead, Joyce.
I'm going to have to leave and go back to, I got excused from the board meeting while they were doing orals, and I have to go back now to vote on that and finish the board meeting. So I wanted to share one idea that I have, which might be a little bit crazy, but, and Dr. Salhever, maybe you can weigh in on this one or just tell me later. So one of the things, when we closed our clinic down for people coming in physically for 2 weeks, we started thinking about when we open back up and doing testing and the idea of doing face-to-face, et cetera. So I had one of our offices that we had the building put in a window between two offices. We have desk face-to-face so that we are actually face-to-face. And we're working on protocols about how we might do that, you know, have where we can hear each other and see each other. So that's one idea that we had to be protected. We've got a space there where patients can actually come in and go to that office where we're never actually in the same room with each other. So anyway, we're experimenting with some new ways that we might do some things. And again, that might be considered too far away from standardization, but we actually are face-to-face. It's real time, and we've got control over the environment there. We won't let them have their phones and things like that. So that's one of the things we're just playing with. I don't know how to work out, but I'll let you know. And I'm sorry I have to leave. It's been nice to be with everybody, and I look forward to watching the rest of the webinar later. Thank you so much, Khiela, for moderating, and everybody have a good day.
Okay, thank you so much, Joyce. Bye-bye. Okay, so if you all could just kind of elaborate somebody had a question regarding just elaborating a little bit on how handouts or whiteboard or share screen has been used, because we know in Zoom, of course, the platform that we're on right now, we're in a webinar format, but when you're in a meeting format within Zoom, of course, I think you can still do that here, but but you can share a screen, you can share videos, you can share YouTube clips, there's all sorts of things that you can share. So if either one of you all wants to kind of elaborate on any other specifics.
Gosh, I do so much with the whiteboard feature in Zoom. I think it's fantastic. Kids really like it. You can arrange it so that they can use the whiteboard feature too, so you can both draw on it. That's really great. Somebody mentioned PowerPoint. There's also there's a website called Therapist Aid that has lots of videos. It's mostly geared around CBT, but it's there are educational videos on anxiety, depression, on CBT components like thought distortions and thinking errors and things like that. It also has lots of worksheets, so you can pull them up and use those as outlines to sort of didactically teach, and then have discussions about life application of principles like all or none thinking or challenging negative thoughts. Certainly one that everybody's using a lot, it seems like, is YouTube. There's just tons of good content on YouTube, from educational videos to relaxation and meditation type things. I've also found myself more and more as a clinician, while we were in person, I have always used some apps like Calm and Headspace to teach mindfulness and relaxation. And then I realized recently that I can share my screen. If I plug my phone in, I can share my phone screen on Zoom also. So we can do like guided breathing and mindfulness practice using the Calm app while using Zoom, and kids respond pretty well to that too. So just some examples there.
Some great stuff, Adam.
Thanks.
On the less technical side, with my veterans, a lot of times, I've just started this obviously, but we will mail out workbooks to them. So like I do a lot of CBTI, so cognitive behavioral therapy for insomnia. There's also a website that the VA has created. It's www.veterantraining.va.gov, and it has an online kind of class/game work around that helps them, guides them through CBTI, and so they can do that online and get the information and start tracking their sleep, and then we can kind of use that, talk about it maybe over the phone if they don't do the video. And I've had that really work with a veteran. She jumped right on board and started doing it, and it really, we had something to talk about, but she was working on it on her own. And then I've mailed some CBTI workbooks, and then, I'm looking at the workbook, they're looking at the workbook, and I can say, look at this is the sleep, diary, and this is how you fill it out, and tell me about, what was your sleep diary like. So, either emailing or through your portal. We have, at the VA, we have My Healthy Vet, which is basically our portal through which we can communicate things. So I have sent like links to different, you can do videos, or you can do handouts or workbooks. We have a part of our health and wellness team, one of our providers created a really great, like, fun workbook for like things you can do that are healthy at home and recipes and stuff. And so they'll mail those to veterans, and we can also send like a PDF to them. So I think, definitely using the platform is really cool. I got to see one of my patients' chicken coops that they worked on for a long time, which was really cool, and their chickens. And one of the patients I'd worked with, even before this, she just wanted to do video because of her schedule. One of her homework assignments was to put curtains on her window so she could sleep better. And so she showed me her curtains, so it's really neat. They like being able to show you the actual things that they've been doing. And it also, I think, helps to add some personal touches to the environment, to kind of the weirdness. And I've also had my cats join sometimes.
Okay.
And that allows them to get to know you in a different way too. And I think that's also part of it. They're getting to know their providers a little bit better through some of this.
I agree.
And it's neat too. Like a lot of my kids on the spectrum that I work with will have a place in their house where they go that feels calm and sort of sensory calming or safe, whether that's outside on the back porch or a special place in their room, and so they can take the phone and go sit there in that space. And I've seen many kids be more open to communicating and talking and through telehealth than in the physical therapy office. So I think that comfortable space really gives them a lot of security.
Yeah, that's wonderful. Thank you all for sharing those examples, and I hope for the attendees that's giving you all some ideas with some of the child, adolescent, and adult patients that you see in terms of maybe creative ways to really think outside of the box and allow this to be an opportunity to think creatively about how to even build further on the therapeutic relationship and rapport, and just really to enhance what we're doing in a lot of ways. Can you all speak to this? Maybe be the last question before we do a brief break. Any kind of bloopers or such that you all have probably run into, or even any of your colleagues even, and just in terms of doing telehealth and the actual, not necessarily, because we're going to move next to kind of technology glitches and stuff like that. So not really the technical aspect of it, because that's going to be in our next segment, but just in terms of the idea of people realizing, I can see you, and telehealth, and they may not, really, they just have to consider that. If you all can speak to that, any bloopers and how you handled that.
So we have somebody in our office who gave me permission to share a story.
Oh, wonderful.
So in working with kids, I think we have this kind of ethical dilemma of wanting to work with, sometimes needing to talk with kids who maybe individually on anxiety strategies or depression or whatever, but you kind of need the parents there too to prevent, keep them in their chairs or to help them stay focused or whatever. But so this one provider had a patient who in the middle of a therapy session said, "You know what, I gotta go to the bathroom," and he grabs the phone and he takes off running. And the provider was like, "Well, wait," and the next thing he knows, he's sitting on the toilet and holding the phone, and the provider's like freaking out. "Oh my gosh, no, I can't. I'll just send you another link." And so he hangs up and sent him another link, and the kid answers the other link while he's sitting on the phone, and he's like, "Hi, I'm not finished yet."
Oh my
goodness. I'll call you, and hangs up. But I think people just forget that there's a camera, and that it's not the comfort of their home. This is a professional. But I also think that kind of stresses how kids are kind of unpredictable in telehealth, and you have to consider this somewhat. So that's my funny blooper. It wasn't me, thank goodness.
Oh my
yeah,
goodness.
So you can just have to hang up and then maybe send another link and hope they don't respond, or maybe call their parent and just let the parent please intervene.
Yeah.
Okay. Yeah.
Yeah, that's awesome.
Yeah. So people just have to really just kind of keep that in mind, because they may have this, it may feel more informal to them because they're in their home, but they have to realize we still have to keep a professional layer there.
Right.
Yeah.
Oh.
Yeah. Okay, Tisha.
Well, I'll tell them myself. So I've done all the training, all the VA stuff, and about how to like frame yourself, and aware of your environment and stuff. And so, when I've been trying to set things up in my house, because I do Zoom from my house from the private practice, I'm like, okay, like what's in the screen and la la la, and it just inevitable that one of my people that I work with was like, oh, I love your wine bottles up at the top with the lights. And I'm like, oh, I on purpose was not going to put my wine bottles in the background. So, I think, and it turned out to be fine, but, I think sometimes it's just like, whatever we try to do, we inevitably are going to do something. And, I think just doing the best we can. But I was like, yeah, they're really pretty.
Right.
My plan this weekend was to get rid of those, but I hadn't gotten rid of them yet. So
yeah. Well, I appreciate you sharing that, Tisha. I appreciate that. Well, let's do this. Let's go ahead and take excuse me, a break to maybe about 3:25, 3:23, 3:24, somewhere there. About a 7 or 8 minute break. And then when we come back, I know we'll just have about a little over 30 minutes, but what we're going to focus on in this last segment will be technology. And it'll overlap a little bit with some of the things we've already discussed a bit, but just how to handle any technology glitches or problems, just some of the technical issues associated with telehealth. Okay, so if the attendees, if you can get your questions ready, and then we'll be back here in about 7 or 8 minutes. All right, so since our panelists are back, probably for the sake of time, I'm going to jump in. And as others are returning from the break, I was wondering if just real quickly before we get into the next segment, we had just a quick insurance question. I know we want to just kind of maybe not focus on that too long, but I do want to focus on, because it is obviously relevant for telehealth. Have you all been facing, particularly with Health Advantage, them not covering kind of the more complex codes, the add-on codes? I know I've seen that with that additional kind of 30 minutes. So if we want to have extended sessions, I know a particular patient who is quite complex that I would see for longer than an hour, and my understanding is that Health Advantage is not covering that additional kind of add-on for 30 minutes with psychotherapy. But have others run into that with Health Advantage?
I'm not expecting to get paid for codes like the interactive complexity code combined with telehealth. I know a lot of us in our clinic are still submitting the same codes. And I ask a couple of times a week in the billing department how that's turning out. And we don't have any verification yet that that's being covered. So I don't think it's going to be. But it may not be the same with all insurance companies. We'll just kind of see going forward, and then maybe that's a role for ArPA to advocate as some of these changes become more permanent.
Right. Yeah.
I'm getting people in the chat. People are saying that their complexity codes are being rejected. So,
You know, one of the things that I'm glad Adam alluded to that is that I working at the VA, don't worry too much about insurance. And then I work with Joyce, so they're kind of taking care of most of the billing stuff. So I'm not very informed about what's happening on the ground. And as the government relations chair, ArPA, and with our team, it would be really, really helpful if people would like document the problems that they're having, ideas that they have, things that, that are working well and are great that we'd like to keep, things that they would like to change, because I think, in the upcoming session, there will be some opportunities to really shape legislation. And if we don't know, at ArPA what's going on, then we can't advocate for it. Also, a big plug for please be members, and please have your friends and colleagues join and be members. The only way that we have the power to influence legislation is with numbers. And so if we say, oh, we're a group of 100 people, that's not going to be as as much as it is if we're a group of 500 people, because we have 500 psychologists, or this is what we represent. So I think it's really, really important that our membership jumps on and it informs us of what's going on and supports us, because we really want to take advantage of this experience and to be able to learn and to be able to shape legislation so that it's supports our psychology community and our patients. And so, please, shameless plug.
Mm-hmm. Yeah, well, thanks for saying that, Tisha, because we wanted to, and I know obviously a lot of this is timely, relevant content and information for psychology professionals and other mental health professionals that are attending, but we also want this to be an opportunity to show what ArPA does for psychologists, for Arkansans, and for the field of psychology here in the state of Arkansas. So hopefully our attendees are kind of picking up on that. Okay, let's transition over into the conversation about more of the technical aspects. Adam, if you don't mind getting us started off, if you could reiterate something you had mentioned earlier when we were talking about this idea of how certain HIPAA guidelines are being relaxed and so forth, and still kind of this idea of we could still use HIPAA compliant software, like is available, is accessible. Do you mind just kind of talking some about the software that you know to be HIPAA compliant? How can people know that, and what software are you using? How are you checking for all of that?
Yeah. So, in order for software to be HIPAA compliant, it has to, two main requirements are there. It has to be encrypting the data as while it's in transmission. If it's stored, it has to meet certain storage requirements. But software like Zoom, for instance, is not storing it; it's only encrypting it. Transmitting it. So unless you're recording the session. But so it has to be encrypted to 256 bits, and you have to have a business associate agreement with the company, which basically is their way of saying that any data that they get on your patients, that it's safe, and that they recognize the privacy. Now, that being said, software like FaceTime, for instance, and Google Meet, if it's not G Suite, is encrypted, but they're not offering a business associate agreement to go with it, so it's not HIPAA compliant. Whereas software like Zoom and VC and DoxyMe are encrypting, and they offer the business associate agreement, so you can use that in compliance with HIPAA. And there's a lot of them, like these. There's gosh, I wish I had the whole list, but there's really a lot of options out there. Some of them are even free, but in some ways you get what you pay for. I know that Zoom has gone from 10 million users to 200 million users in the last month. And they've, there's been some news stories about some of the problems there. And I get regular email updates. We use Zoom, and we have several clinicians in our office. So we have 21 licenses with Zoom. So I'm in contact with them, and they're sending emails regularly about all the security updates and things that they're doing to fix it. But it's been, despite some of the issues there that have unfolded, it has been really reliable for us. And I hear a lot of complaints about some of the others. So I've been very happy with it. I've also heard that Google Meet, if you use G Suite, which is the paid version of Google products, that is also, you can get a business associate agreement, and that can be also a HIPAA compliant version that would be free. It would be the price of G Suite, which is like, depending on the package, $6 or $12 a month. So.
Mm-hmm. Yeah, Adam, if you could kind of elaborate a little bit on the part that you said that Zoom is kind of addressing some of the issues that they've been having. Because I know I had a particular family to reach out because they know we're using Zoom, and they reached out and said, hey, do you guys know about this Zoom bombing or that's going on, this hacking, and was concerned about what our agency was doing to address these issues. What are your thoughts about that, and what do you advise people to maybe say to patients that are asking?
Yeah, so Zoom bombing is, in a way, it references like photo bombing, right? So it's people jumping into your session and doing obscene things. So what Zoom did to prevent that from happening, well, let me go back and say how they were doing that was, for each Zoom session, you get about a 9-digit code, and you enter that in, and it pops you into the session. So with 200 million people using Zoom, let's say online vandals could just randomly guess 9 digits and get them right every now and then they pop into somebody's meeting. So what Zoom did is they made by default that all the accounts have the waiting room feature enabled, which you could have, a lot of people were using anyway, and really works well. So what that does is when somebody joins a meeting, as the host, you have to let them into the session. So if they were to jump in, they can't do anything but wait. So once I heard this, we enabled ours immediately, and then later on they made it default. It also helps to have passwords and things like that in place.
Mm-hmm. So it sounds like once the encryption is in place, and of course, like you said, having the business associate agreement is just a good thing to have. But then when you have enable the waiting room and have a password, that's increasing the level of security of the platform that you're using.
Yeah, there was also some questions about encryption, and they're doing everything they can to increase their security. It's kind of their day in the sunshine, so I'm sure they're working really hard on it. We've been happy with it. If we had to switch, we would go to Google Meet, because we have the paid version.
Okay, so there would be another kind of high security option.
Mm-hmm.
Adam, is it true, like even in our Zoom webinar that we have here, that the encryption icon, is it that green? So if people wondered, oh, how would I know for sure? Is it that green kind of lock kind of icon at the top of our screen?
Yes, that's it, top left.
Okay.
That's demonstrating that it's encrypted.
Okay, good deal.
So one thing I think that's kind of neat about this is just that I've observed is all four of us on this panel have different mic setups. And so the audience can see what the differences sound like. So the best one should be Tisha's with the mic and headset. I'm using a separate mic, and Khiela's using a built-in computer mic, it looks like. And then Joyce was using a headset, but not as but more of a, I don't know, less quality headset than Tisha's. So right, so you should be able to, the audience should be able to hear the differences and know what they sound like with their options.
Yeah, and so there was going to be another question, and Adam or Tisha, whoever wants to kind of jump in on that. That's what I wondered about, and people are wondering about quality of their video and audio. Assuming that like this is going to at least be going on for at least the next month or longer, we don't know. What are some ways that people can improve the quality of their video and audio when working with patients?
Some of the biggest things and easiest thing to fix that I've seen my patients doing, that I'm sure clinicians are doing too, is not being aware of the lighting. If you angle yourself in the wrong place, then you're just gonna blind yourself out. For instance, I have a lamp now above my computer, and I have windows behind me, so if it's bright enough, I should darken out without the lamp. And so, that matters when your patients are looking at you. If they can't see your micro expressions, then, they're not going to feel as comfortable. So just a simple lamp can kind of change the arrangement. Or just turning. If I didn't have a lamp, I would be facing the other direction, so the windows would be shining light on my face. And for me personally, then I don't have access to my cord to plug in or my mic because the cords aren't long enough. So for me, a lamp was the easiest way to go.
Yeah, for me, I really focus on, as much as possible, having some natural light that's coming in and not behind, because if the light's behind you, then like Adam had talked about, it makes you dark, and it's hard to see your expression. So if I'm at home, I have a place where I sit where my window is right there, and then here at my office, I'm lucky that my computer faces the window. And see, if I did something like this, right, like now I've got this light behind me, there's different ways that this could be configured that it would not be as pretty, right? And so I worked really hard today to find the best, kind of configuration where you could see me and the background wasn't so distracting and I didn't have lights. So, I think that really makes a big difference about how, kind of the whole experience.
Yeah,
if you're straining and it's not aesthetic, then it's distracting.
We're setting the scene for our patients, even though we're on telehealth. I'm still seeing all my patients from the office, just to get out of my own house where my own kids are. So a few of the clinicians are up here seeing patients, but when a patient sees me on telehealth, they're seeing the office that they used to come in, and they see like child-friendly things behind me. My thought is that should be comforting and make them feel a little bit more at ease with the telehealth process.
Yeah. And so, and even from I appreciate both of you all mentioning that in the background, so people can probably tell I'm here in my home. Sometimes I'm at the office and I see patients while I'm there at the office, and sometimes I'm here, and sometimes that's the first things patients say, like, where are you? And that allows for a conversation. But I think we have to be mindful about like what's in our background and thinking about that, and like you say, kind of setting the tone and setting the stage for the session. So thanks for mentioning that. Have you all addressed any kind of glitches that have occurred? I know, Tisha, you've mentioned, of course, having backups and the phone and so forth, but just from a technical standpoint, what are some ways to address that when it's freezing, just within the technology, not necessarily right now going to backup, but within the technology itself, what are some ways to get that straightened out where it didn't freeze as much or the call doesn't drop.
One piece of it is recognizing that, so everything that it has to capture and take, and it takes bandwidth. And so like some of the recommendations and some of the trainings are to make sure that your background is kind of as calm as possible, and the more bandwidth it takes, the less quality of a that you're going to see. So it's really important, like what you're wearing. You're not wearing lots of wildness, and you don't have a lot of things in the background. The less that it has to kind of process, the better.
Mm-hmm.
And also, I think a really big thing is, is making sure that sounds don't overlap. And so like if they're talking and you've got something and like a dog barks, it's going to make a sound, which is going to cause them to kind of mute out for a second. And so if you're not talking, you can mute yourself so you can really hear them, and they go through clearly. And then if they're speaking, or if they're not speaking, sometimes they can mute themselves, especially if they have background noise, and that will help them to hear you clearly. So there's not this competing sound, because you can only hear one thing at a time. I think you guys, everyone has probably saw that whenever one of us tries to speak over the other person, or there's background noise, it starts to be a problem. So really using the mute judiciously.
Yep. I think sharing screens takes bandwidth too. It seems to slow it down a little bit. So anytime that I'm working with somebody who's having some internet issues, I won't do that. That's probably the biggest problem that I've seen is clients having unstable internet, and it freezes up every now and then. And so sometimes it just means they need to go to a different room of the house. They might need to go upstairs. Sometimes if they can, that means turning off the Wi-Fi and using cell, if that's an option for them.
I had someone last night that I was working with, I think it was last night, Wednesday night, that their phone for whatever reason wasn't working too well. They have like a 6, and so they switched over to their computer, and it was much better. So sometimes changing platforms for you and for them, if one is not working so well. I got an iPad that will use Wi-Fi and use cell. So if my Wi-Fi at home is not working so well, then I can switch over to my cell service and still use that. And from what I've heard, cell service is more constant, that our Wi-Fi will kind of move in and out, and so that'll cause some of the glitches. And so that's one of the reasons why I chose the iPad that has the cell option, so that it can have a better quality.
Another thing that really helps is knowing the software you're using well, so that you can coach people through it. There's a text from Glenn here, and I agree. I was going to bring that up too. Is being able to run a sound test on your own, which you can do really easy on Zoom. You can test your own mic and speakers quickly to know if there's an issue, whether it's you or not. But you can also kind of coach them through if they're having issues, what should be selected and what shouldn't, for instance. So knowing the system, I think, is a big part of it.
Yeah, I definitely agree with that, because that was even one of the recent issues that I'd had. What Glenn is referring to is the audio, and my mic was just kind of going in and out, and I didn't know. I had to call the company and everything. But I think it could have been as a result of a number of different issues. But I agree with what you're saying, just ways of really knowing the software, knowing the computer, knowing all of what you can do to kind of rectify that. So it was some times where I even had to call into the session somehow with another device, with my phone, just so we could still have or just get on the phone as an audio, but still have the video up. But definitely, so Glenn is talking about how he went into the audio settings and then was able to correct the source for his microphone and make sure it was accessing the appropriate microphone.
Most things seem to be fixable that way. It is nice, though, that there is the setting where you can use a cell phone audio. So you can call in with your phone and use the video from the computer, and have a fine session even without a mic on your computer.
Mhm.
Yeah, I think that can be a really good option, especially in Zoom. I know that I was part of I think it was a meeting. I don't think it was actually a patient, but that sometimes when the bandwidth isn't too good, you can see people, but you can't hear them very well. And so they're going in and out. And so you can still kind of have it on, but you can call in and you can at least hear what's going on. They might be a little, they might freeze every once in a while on the screen, but you can at least hear them consistently.
Absolutely.
One thing
I've done that.
Shannon's bringing up an interesting issue I forgot I wanted to bring up earlier when we were on the ethics conversation. But so in our clinic, most of us didn't give out emails to patients before the COVID crisis. And then we, in order to use Zoom, it's really difficult to not give out your email. So pretty much all of my patients in a matter of like 2 days have my email. And then since she brought up the idea of, well, what if your patient's wearing something inappropriate? But yeah, I mean, I think using telehealth, you have more access to your patients, they have more access to you, and there's the issue of what is behind the camera. I think it requires us to have good boundaries and to be more assertive with patients. Even, take it a step further. I mean, you even have to pause your session early and schedule appointments for the future. You have to collect copays, which for people in our office, we have staff that are doing that. So it's kind of a different thing now for clinicians to have to do that. So there's several areas where we've had to evolve our boundaries in order to make the telehealth work ethically.
Yeah, I'm glad you did mention that, Adam, around the boundaries and the ethics, because that was a question that I was just going to have is how is this changing the dynamics within the therapy relationship? Then, yeah, like you said, having access to our email. And I even had a family email me and I said, I would think you would never would have contacted me between sessions about this. But now since you have my email, you're reaching out in a way that you never would, which can be a good thing, but in some ways still a boundary issue that has to be balanced. I think
for me, the email thing was something I had considered for a long time because I know that patients really love to have access that way. And I felt like could be a good thing for treatment for many of my patients, but it can also be abused, which was what I feared. So, for me in the last month, it's been fine. I've not really had to set firm boundaries. Nobody's really abused it. It's been helpful to have updates between sessions on a couple of clients. So I've sort of embraced it. Glenn mentioned that, and that's true. You can do Zoom without giving your email. You just can't invite them from the Zoom session. They have to go in and put your ID in order to join. So just a different way of entering, which at the time I don't think we knew. So either way, we've all done it now. So
already, yep.
Yep.
And I'll say from, doing DBT and phone coaching and being a little bit more used to having contact with people between sessions, I think it's just so important to set those boundaries, and this is what this is for. And, email is still not a good way to tell me that you're suicidal, and, just kind of setting those ground rules and reinforcing and having conversations when things are not used as intended. I have for a while, because I'm working in the evenings and my patients sometimes have a hard time getting hold of me, and I am not going to, be doing my private practice stuff while I'm at the VA. I have used a secure text program called OHMD, and basically it allows you to they don't have your text message, they don't have your phone number, they just have your kind of office, but you can send text messages to them and they can send text messages to you. And for me, it's used totally for things like changing appointments and running late, or I have used that as a way to give them the messages for the Zoom meetings rather than phone. But again, that's just kind of depends on what works for you and your comfort levels. But I have found that to be very helpful, especially during this time.
I'll
Of,
say some systems have text built into it. Like I think Simple Practice, you can text out and it's coming from the office rather than from your phone. And then some phone systems like Vonage and Ring Central, you can text from your office phone, and it's not your personal cell phone. But a lot of clinicians use email and phone regularly, and always have. It just wasn't common in our clinic. So, but it is now, thanks to COVID.
Yeah. And what was the name of that? Go ahead. Yeah.
Oh, it's OHMD. It's like OMD, which I really dislike, but
But that's
like
what it is.
But it is, I mean, basically you have to initiate it. So you send them a text with their phone number, and then they sign up for the service, and then it gives you alert, just like a text message. It gives you the alerts, but it doesn't give them your cell phone, and theoretically it's HIPAA compliant. They say they are. So,
Okay. Yeah. Okay. Well, thank you for those for that resource, Tisha. Is there anything still regarding the technical issues? Have you all seen any increased challenges with since we are having to use our technology a lot more often with anything around malware or viruses or anything? What are some suggestions about just ways to protect against that during this time, and even things we can encourage our patients in around viruses and malware from a technical and technology standpoint?
It's always a good idea to keep your software updated with the latest versions, whether it's Mac or PC. They're constantly finding holes and fixing vulnerabilities. So I think, gosh, that's definitely a must, is keep all your software up to date. If you're using Zoom, especially your Zoom software up to date, because they're updating it constantly right now. Other things, we're living on our computers now, so I feel like the computers are more vulnerable. Being sure you're using passwords and changing passwords pretty often, and having a real password, not your dog's name or your address or that kind of thing. There should be capitals and lower cases. There should be numbers and some kind of special characters. But a good password could save you a lot of headaches.
Yeah. And, I think that goes back to when we were talking about like what HIPAA compliance or things being relaxed. I think just because things are relaxed doesn't make it safe. And, recognizing that for ourselves and for our patients that, even though we can do something, it doesn't without a lot of penalties right now, it doesn't necessarily mean that it's the best thing, because there are, there's a lot of people who are trying to take advantage through phishing, to get people's personal information. And so really working hard to protect our patients and their personal information, and protect our personal information so that we're not exposing them to risks that aren't necessary, just because we can at this time.
Yeah, keeping antivirus and malware or spyware up to date. Another thing I think maybe to consider is be sure you're on a secure Wi-Fi. You don't be using Wi-Fi that's not password protected. If it's open source, then it's dangerous. So you're better off to hotspot your computer than to do that.
Yeah, and also explaining that to your patients too. Like, don't go to, don't sit outside the McDonald's parking lot and use their Wi-Fi. Or if you do, it's not secure. So,
just so they know.
Yeah.
Okay. Well, thank you all for that information. Any other kind of miscellaneous topics that I did not include from the technical glitches, or anything that you all have run into that's been helpful?
I think that's got all of mine.
Okay.
I think I will just maybe say that there's a lot of ways you can use cloud storage now for that's HIPAA compliant. And if you store your information there, then you're not dependent on your device. So if something happens to your computer, you can just replace it. if it's stolen, you don't have to worry about all your patients' data being on it because it would be stored in a cloud somewhere. So that is good. I think most security folks would consider that the safer option.
Okay. All right.
Yeah, I know that we use the Google Suite at the Fowler Institute, and we communicate via there and keep lots of all our stuff on there.
Yep, that's what we do too.
Like our charge tickets and stuff.
Do you all see the question regarding cash pay clients? Can PayPal or Venmo be ethically used? I think I'm saying that.
I think the issue, somebody may be more of a HIPAA issue, a HIPAA expert than me. My understanding is that that most of the pay sources like Square and PayPal are HIPAA compliant in the transmission of data. Well, let me just say they're encrypted in the transmission of data. But if they're sending receipts, then that's stored data and that's not the same. So I think you have to investigate that for yourself. I don't know about PayPal specifically, but I do know lots of people are using it. But I would want to know if you can get a business associate agreement from PayPal. I think you can now from Square. I would also wonder about Stripe and some of the others. Yeah, there are HIPAA guidelines that address that specifically. So whoever asked that should read into it. Okay. So the easiest way to do it is to use one that's built into your EMR. So then you know that it's secure.
All right, thank you for that. Are there any kind of wrap-up comments that you all would like to make? Just any last words regarding telehealth, and specifically, like even if it's something specific to Arkansas and people providing services to folks here in Arkansas?
I like the comment from Debbie. Nice to know we're all learning as we go. I am supervising an intern here at the VA right now, and this poor person who has we're trying to figure out how to do our work, let alone train him. And my thing is, I keep telling him we're flying this plane as we we're building this plane as we fly it. So I think we are I think as psychologists, we are very well trained to be flexible and to know kind of the guidelines and do the best thing for our patients and the people that we work with. And I think whenever, we still look at our own ethical principles, they all apply here. And so, and consultation, I think this is a big, part of our psychological association and part of our profession is that there's always someone in your profession who knows more about this than you do. And I know for me, I'm certainly not the most knowledgeable person here, just the person who was able to do it. So, I think always, relying on your colleagues and learning together. And I'm always, at most everyone knows how to get a hold of me. And if you have a question that you feel like that I might be able to be helpful with, I'm happy to help. But yeah, we're all in this together.
Yeah. Yeah, I just want to add, this is a historic event, and we are, as mental health providers, we're living through it and adapting. And I've been really pleased to see how we've done this as a field. I mean, it seems like overnight, or well, literally like in a week, like all of mental health in Arkansas just went telehealth, and we did it. And we've, relied on each other, and it's been really amazing to see this unprecedented time for us. So.
Yeah, absolutely. And I know ever since I've joined ArPA, I think it's back in 2009, that I've just seen how this group of psychologists and folks just kind of come together, and really the mental health community broader here in Arkansas really does come together and rally to address some of these issues. So I appreciate your panelists being here and taking out of your time and sharing your knowledge, because it really is a good collection of knowledge that we have within our association. And so we're just glad to have the opportunity to to share that. And even going forward, I know just as Joyce mentioned and some of the other panelists has mentioned, that we just want to have to stay up to date at all of the information that's unfolded on a day-to-day basis. So please continue to check the Arkansas Psychology Board's website, or whichever licensing board that you're affiliated with. Please continue to check that, and any other information that's unfolding regarding insurance or any other parameters that we need to be mindful of. And as ArPA, we'll do our best to continue to get information out there that's going to be helpful and relevant and timely. So as we wrap up in these last couple of minutes, the only other thing I want to do is discuss how you're going to get your CEs. So for the folks that registered and also requested and paid for the CEs, there will be 3 CEUs offered for this webinar. And so after this, we do have a way to track the people who did request that. So we have your email addresses, your names. And so what we'll do is that our executive director and our team will get out the information, the certificate, to those who registered with CEUs. So you should receive that within the next few days, I'd imagine, the certificate by email. If you have not signed up to get the CEU, just send an email to the office, I think at arpasite.com, I think it is. ArPA, yeah. To our email address.
I think it's .org.
.org. Okay, office at arpasite.org, and then just let us know, and then we can kind of work with you for the, okay, yeah, office at thank you, Tisha, at arpasite.org. So if you could send that and just coordinate with us regarding paying for the CEUs, we could potentially still do that. And so next week, so we have a message, so probably next week for the CEU. So within a week, so if you all could give us just a bit of time here, and within the next week, you all should be receiving that via email. Thank you, attendees, for being on and staying with us throughout these 3 hours. And again, the recording will be made available within a week as well. So everyone, please enjoy your weekend. Stay safe, stay healthy, stay well. All right. Thanks again, Adam and Tisha. We appreciate it.
Thank you, Khiela.
You did great.
All right.
Bye, everyone.
Bye.
Okay.